Thank you, Kumar, for asking me to participate in your very popular course, and thank you, Samresh, for your very kind introduction. I'm going to show you a series of different cases where the lens was behind the posterior capsule, partially or completely, and how we have managed them. So this was a patient that came to me, east-west decentration, and preoperatively, if you see carefully, the lens margin bisects the pupillary area. On dilatation, this is seem to be very, very significant. As expected, the quantity of vision is not satisfactory. It is only 618 with best correction. And we also expect the quality to be affected because of the age and the dissented intraocular lens. And if you look at the higher order aberrations, the entire eye, is full of them, and it is not coming from the cornea, it is an internal aberration. So it is coming from the intraocular lens. So definitely we need to do something active for this particular case. Now, if you, this is how I develop my game plan here. So the intraocular lens is in the back. You have to believe me because it is not very clear. The rhexis margin is scallop, it is round, east-west decentration. Fortunately, for me, it is a 3-piece hydrophobic acrylic intraocular lens. So most probably the lens had migrated nasally through a peripheral zonular dialysis, a large posterior capsular lens in the periphery. So it had tended to go behind to the posterior segment. Fortunately for me, again, there was no vitreous in the anterior chamber. Rhexis appeared to be pretty stable, well-centered and scalloped, and the back, by and large, is very stable. So I decided to fixate the lens using the capsular bag. So this is how the surgery goes. I plan to make it a totally closed chamber maneuver. So 2 paracenteses were created, and no, the incisions are not going to be opened up. So use a copious amount of a dispersive OVD. You need to protect the corneal endothelium. We need to protect the anterior vitreous face here because vitreous face is still intact. And open up the bag, inflate the bag. And my plan here is basically going to be, dial the lens within the capsular bag itself, keep it in a different axis, and obtain a reverse optic capture. So this lens optic will be pushed anteriorly so that it comes in front of the rhexis margin, and the whole capsular bag sort of supports this lens. So this is going to be my game plan, and the visco-shield, visco-protection strategy is going to be very, very crucial. Make sure that the incisions are made through the virgin areas, because if you go through the older clear corneal incisions or scarred areas, at the end of the day, at the end of the surgery, it's going to be very leaky. You may have to even put sutures. So it's important to select new areas, virgin areas. Make the manipulations as atraumatic as possible. In this case, the anterior capsule is sort of plastered to the anterior optic surface. So I was very careful. I have no business to rupture the rhexis margin here because I'm going to use the rhexis for my reverse optic capture. So one has to be very careful. Using the Sinskey hook, the lens is carefully dilated, rotated, dial, and now I will be keeping it in this particular axis. So this is more or less going on quite uneventfully here. This is the area of the visible area of the post PC dent, prior PC dent, and it goes behind. It is not. It was a large vent, and it was the leading haptic which is going through the PC dent area. So here again, I injected some more OVD, protect the anterior vitreous face, and then obtaining the reverse optic capture using a bimanual technique. So the nasal side has to be done crucially because the capsular rhexis margin is fibrosed here, and it may tear any moment. It may not stretch as much as what we achieve on the temporal side. And once the one half of the nucleus is prolapsed anteriorly, anterior to the rhexis margin, the other half, the temporal portion, is easy for me to prolapse. So this is done with just the Sinskey hook. And at the end of the surgery, if you see here, the lens is very well settled, centered. It is the tap test is negative, so it is going to be very, very stable in the long run. So this is how I started the surgery. This is the end of the surgery. On the first post-op day, the patient had a vision of 6/9 partial, and see it is this is the post-op picture, well centered, and all the internal higher order aberrations that were coming from the entire eye is gone. A little bit of corneal astigmatism has been induced, but patient has done extremely well. His vision has improved, her vision quality also has improved, and he has done fine. So I just like to show you another 2 videos. Now, this was a patient again referred to us with a dropped intraocular lens in the posterior segment. And if you see carefully, there's a PI, its aphakic rhexis appears to be intact. The intraocular lens is lying in the posterior segment. So this was a case which was done a dual, with my posterior segment partner. So she did the vitrectomy. It is important to perform a total vitrectomy and remove all the additions between the lens and the vitreous here. So here again, the game plan is the same. The anterior capsular rhexis, the rhexis was okay, was intact. Most of the anterior capsule was there. And I'm planning here is to dial the lens into the ciliary sulcus. So at this point, I take over from the posterior segment surgeon after the vitrectomy is done, after the lens is mobilized. And then, so now I go to the main ports. Yeah. So here, so now I'm working through the through the sclerotomy port here and exteriorize one of the haptics. So it is always better to do it that way. So once you have extended the haptic, you have full control over the lens, and you can really dial it wherever you want to. So I first put it in the anterior chamber because since the precedent was large, I was not really sure whether my haptics will go into the ciliary sulcus, graze anterior to the lens capsule, anterior lens capsule. So it is better to have the lens first in the anterior chamber, and then under careful monitoring, dial the haptic and keep them gently under the iris, tuck it under the iris and just let it open up. So it goes to the sulcus. And then again, I try to obtain a standard optic capture buttonholing of the lens. So the rhexis was large. I do not know to what extent it was successful, but post-operatively, the lens was very well centered and patient was also doing quite well. So this is the last case that I'm going to show you. So again, another patient that was referred to us. This patient had a scleral tunnel cataract surgery done, small incision cataract surgery, and had a rigid lens which was dislocated into the posterior segment. So again, the anterior segment surgeon does the groundwork for me, does the vitrectomy. I myself have learned how to perform a past-span anterior vitrectomy, but in this case, the lens is lying on the posterior segment. So this is a rigid lens. So what the surgeon has done here is after doing a poor anterior vitrectomy, the same lens is grasped with the micro forceps, and then it is dialed as I had told you earlier using the same principles. It is first brought into the anterior chamber in front of the iris. So all the manipulations are happening from the side port, from the pass-band incisions, and the same thing is done for the other haptic. So I have the entire lens, the entire rigid lens lying in the anterior chamber, and then subsequently the same compression and dialing technique will be employed to gently place the lens place the haptic behind the iris into the ciliary sulcus. So the same thing was done for the trailing haptic. And sometimes, even if the lens goes into the sulcus, you may see some iris stuck in the periphery. So you may need to manipulate a little bit on the peripheral iris to give a round pupil. So this is how the post-op picture look like. So many cases of decentered or dislocated PCIs can be reposited simply by employing residual capsular back support using proper surgical techniques with good anatomical and functional outcomes, which were demonstrated in this series of 3 cases. Thank you so much.